Well, good evening, everyone. My name is Howard Weiss. I'm the moderator for today's discussion, and we have a real treat tonight. We have Dr. Yasser Torresyaghi as our guest speaker. He's certainly one of the young generation of young Turks in neurology who's done some very special training, not only in movement disorders and Parkinson's disease, but also in some of the cognitive issues that can affect our patients. And in fact, Dr. Yaghi is the director of the Parkinson's disease and dementia program at Georgetown University Medical School. He did his undergraduate training at University of Chicago, medical school at George Washington, and he's been at Georgetown since his neurology residency and his movement disorder fellowship. So I think we're in for a real treat tonight with his expertise, and of course, after the program, there will be a question and answer period. I just want to mention today that this program is being recorded and will be available afterwards on the Maryland Association for Parkinson's Support website. And I would like to also ask those of you who are participating to complete the survey forms after the program, because this is very helpful in us in evaluating our programs and whether we're meeting the needs that you have. So without further ado, I'd like to introduce my colleague and friend, Dr. Yasser Torresyaghi. Thank you.
Dr. Weiss, thank you very much for such a wonderful introduction. It's an honor to be able to present to everybody, and to be introduced by Dr. Weiss is a great honor as well. So thank you so much. This is a topic that is very, very important to me. As I was trained in my fellowship, I really became more and more involved in really understanding not just the motor aspects of Parkinson's disease and patients with dopamine deficiency, but also the cognitive non-motor aspects of Parkinson's disease. And my goal today is to give us an overview of everything that has to do with cognition in Parkinson's disease and Parkinsonism, but at the same time remain hopeful and positive about all the different things that we can do to help. If we can identify a problem, our goal overall as clinicians and as diagnosticians and as neurologists, when we put on our detective hat to understand exactly what's going on, it's because we want to find a solution for an issue that is affecting our patients' quality of life. And when cognition is in the picture, it really can become something that we need to focus on. And I want us to also think about the different therapies for the different cognitive aspects of Parkinson's disease and Parkinsonism. So I used to tell a story when I just finished my fellowship in 2017. It was 34 years, including preschool, that it took in order for me to finally finish and become a subspecialist in movement disorders and memory disorders neurology. And that was 2017. So I used to have a slide like this where I would say, if you really think about when Parkinson's disease was first described, it was about 204 years ago now. And it was first described as the essay of shaking palsy by James Parkinson. It wasn't until later that we really started understanding the way that Lewy body pathology moved within our central nervous system and created a lot of the symptoms that it is that we talk about in Parkinson's disease. Here you can see, when we think about the progression of Lewy bodies throughout the brain, we see that Lewy bodies, or that protein that accumulates, their alpha-synuclein, as it accumulates within the neurons, it can go through and course through the central nervous system and create the different symptoms depending on where in the brain we see that Lewy body pathology. And that's what brings about, when we think about the motor symptoms of Parkinson's disease, we think about bradykinesia, a slowness of movement. We think about maybe rigidity, postural instability, and tremor. And we make sure that we know if a patient looks like they have Parkinsonian motor features, that's important. And understanding those motor features and that phenomenology as a movement disorder specialist is so important, because it allows us to at least have a clinical underlying strong suspicion that we're dealing with a dopamine deficiency. So what we might see in a patient that comes in either through our movement disorders clinic or our memory disorders clinic, we might see features of tremors, rigidity, slowness of movement, or postural instability. And we have a potential diagnosis of a Parkinsonism or a dopamine deficiency when we put it all together. But you might notice that we do other diagnostic steps in order to really understand the whole picture and to be able to understand the cognitive aspects of our condition. Understanding what the brain looks like with an MRI is very, very important. You might also notice that a DAT scan or a dopamine active transporter scan helps us also potentially with a neuroimaging biomarker to diagnose a dopamine deficiency or a Parkinsonism. You might also see that we'll do our movement disorders examinations. A lot of our patients that come through our clinic and all of our movement disorders clinics sometimes make a joke because they know where we start off with our examination, or at least with me, a lot of the times I might start off with finger tapping, understanding if we have a rest tremor, asking our patients to kind of sit calmly, do different movements or maneuvers of their arms and legs to determine the amount of symptoms that we see and put it into a unified Parkinson's disease rating scale, severity scale, meaning the higher the score, the higher the motor symptoms. And we might think about the different stages of Parkinson's disease in terms of Hoehn-Yahr stages. We might also ask our patients to draw a spiral to be able to diagnose, does the spiral look small? What sort of oscillations do we see? Is there a dystonic component to a spiral? But that's not all. And I hope I kind of breezed by those motor testing skills that we learn in our movement disorders fellowship. But our goal also is not to neglect the cognitive and memory dysfunction that might occur in our field. And if we can really make sure that we don't neglect that aspect of things, we can usually lead ourselves down a more successful clinical treatment path, a strategy of treating not just the movement disorder, but also the memory disorder that might be part of the entire picture. The good news is there's a lot that can be done to help with cognitive change in Parkinson's disease. And I want everyone to kind of keep that in their mind as I continue to go through this educational presentation. And so what we see here is, if you think about the standardized tools we use, and I'm going to go into it a little bit more, we do mini mental state examinations scored out of 30 points. There are different questions that we ask, different tasks we have our patients do. Same with the Montreal Cognitive Assessment. But we also use diagnostic tools. We might do imaging, like I mentioned earlier. We might do lab tests. If a patient has some cognitive change, we might want to check their thyroid function or their B12 level, folic acid level, maybe some other electrolytes, or B1 or thiamine, which can also affect our cognition. And we want to make sure that we're thorough in our diagnostic analysis. We might think about depression screening, because we know Parkinson's disease and depression oftentimes are related. And then we may want to do an in-depth neuropsychological screening, which is something that we also do, in addition to other things. So when we look at the entire complex, Parkinson's disease and that tip of the iceberg, the movement symptoms are just the tip of the iceberg, right? There are a multitude of different areas of our nervous system that are affected. You see underneath the surface, under the water there in that picture, you can see way below the olfactory cortex, or the sense of smell, our temporal cortex, or the part of the brain that helps us in understanding sound, understanding language, and storing memories. We might also see that there are parts of the brainstem that are affected, or the pons. These are all different aspects of the central nervous system. But I want us all to think about it in terms of a complex. This is a Parkinsonian complex. The brain, of course, and movements are very affected, but there are other parts of the body that, of course, are too. And so if you look on the left there, you might see the neuropsychiatric and cognitive symptoms that we always screen for. And I'm going to take a deeper dive into this icy water, as you see with this picture with the tip of the iceberg. I'm going to take a deeper dive to understand a lot of these cognitive things that we look for, because there are a lot of things that can be done to make our patients feel better, to alleviate these symptoms. And that's our goal, to think about that positive therapeutic strategy that can lead us to positive impacts and improvement of symptoms. So we screen for depression, as we mentioned. Anxiety, of course, is part of Parkinson's, but also part of the neuropsychiatric overall complex of our cognitive ability. We screen for things like hallucinations, like psychosis, or some fixed ideas that might be scary. We search, of course, for dementia with our different tests, as we mentioned. Remember, cognitive impairment is part of Parkinson's in many cases, and that's okay because there are different things that we can do to help. We also evaluate for periodic confusion. Things like infections might cause some periodic confusion, or things like wearing off of our Parkinson's medicine might actually lead to a feeling of brain fog or slowing down of our ability to think through things or communicate. That in and of itself is part of cognition, right? Or things like apathy or feeling like things are not as fun as they used to be. Or things like fatigue. Fatigue in general can also affect our ability to think through things and our cognition. Of course, we can't talk about cognition without understanding sleep disturbance, right? If we have patients that find it difficult to fall asleep, are suffering from sleep apnea, which can affect our patients and lead to daytime somnolence, fragmented sleep. It might be easy to fall asleep, but it might be hard to stay asleep, right? We might feel crummy in the middle of the night if our Parkinson's motor symptoms stop us from being able to sleep deeply. And then, of course, REM behavioral sleep disorder, acting out of our dreams. These are all part of our overall Parkinsonism complex and the cognitive or neuropsychiatric and cognitive aspects of our condition. So we talk a lot about the non-motor symptoms of Parkinson's. And what we see here is a trajectory over time and what it is that we're really focusing on. And you might see right there after time 0, you see how we talk about the different motor symptoms and the non-motor symptoms. But right after time 0, right above that, you see MCI. And I still remember every time I use the acronym MCI, I still remember the telephone company, which I no longer hear about. But MCI really means mild cognitive impairment. We might see some cognitive change, some impairment of our ability to think through things, short-term memory dysfunction, maybe some inattention that can be part of early Parkinson's disease diagnosis. And earlier than that, we might see neuropsychiatric symptoms like depression or other features that might precede the diagnosis of Parkinson's disease in many cases. But later on, we might develop a larger degree of cognitive impairment. Now, the difference between mild cognitive impairment and dementia is functional impact. So if we find it hard to be able to care for ourselves as a patient, do things like brush our teeth, take showers, get dressed in the morning, take care of our home, things that are called activities of daily living, those are things that we screen for, make sure that our patients are able to take care of themselves and take care of their family, of course. And if we start seeing those aspects affected, that's when we start moving our way into the realm of dementia. And then later on, we might start seeing some things like hallucinations or delusions that we need to screen for. And so you might notice that we use different rating scales. And part of our entire rating scale in our clinic, when you go in to see your doctor or your healthcare team, the PA, the nurse practitioner, really is a team that takes care of our patients. You're going to see we might ask questions about cognitive impairment, about our mood, about our ability to do these things, our activities of daily living, in addition to the motor symptoms. And we might really take even a deeper dive, use our non-motor symptom questionnaires sometimes to understand, what sort of aspects are affected. Are we losing interest in our surroundings? Are we feeling nervous or worried or frightened about things? Are we feeling that our ability to think through things is affected? Are we able to experience an event and then be able to recall it, even if it happened a week ago? We might talk about sustaining concentration or understanding if we're able to focus, if we have any inattention issues. Remember, that's all part of cognition. Memory is one piece, but attention is another part. Do we have difficulty remembering appointments or remembering how to do things? Remembering how to use domestic appliances at home? Are these things becoming harder for us to do? These are the types of things that we really look for. We ask our patients about. So we talked a little bit about our cognitive screening tests. But we also, for mood screening, which is part of cognition, we do our best in trying to evaluate the extent of mood changes that might happen in our patients, right? So we might do things like a Beck depression inventory, or a geriatric depression scale. That's something else that we might ask about. Those are all the types of things. The reason I bring it up is because there is something called pseudo-dementia, or depression-related cognitive disorder. Why am I speaking so much about mood? Is because a lot of the times, if our patients, and we know our Parkinson's patients can sometimes have difficulty maintaining a happy mood. If we have a low mood or depression or anxiety, we might actually have what's called pseudo-cognitive impairment, where we find it hard to remember things, but not because we have an organic cognitive problem or a deficit in terms of our cognition. It's actually that our psychology can slow down our ability to think through things. Our cognitive agility and our short-term memory and our ability to focus can actually be impacted negatively by something like depression. And we first really noted this after soldiers returned from World War II, and we were able to see patients that actually looked like they were having issues with being able to answer questions that had to do with evaluating memory, or they were having difficulty with attention and concentration, when in reality, it wasn't an organic neurologic diagnosis like a cognitive impairment or dementia that was occurring. It was actually a psychological change that had occurred that was leading to depression or anxiety that was impairing our ability to think through things cognitively. So that's a very important piece. As I mentioned, when we use our screening tools, our goal is to make sure that we're not missing that aspect to cognition, that mood aspect, because there's plenty of things that we can do about it, right? We can think about psychiatric care, therapy, caregiver support, community support. How do we help our patients and our families feel better? Not just support them with medications, not just support them neurologically or with exercise, which is important, of course, but also support them psychologically. That aspect of care is very important. And then, of course, we can think about medications such as the SSRIs, things like citalopram or escitalopram, which are selective serotonin reuptake inhibitors that can be helpful, and other medications. Even our dopamine therapies, the medications that help our movements, can in fact improve some low mood in Parkinson's disease. So all of those things are important. Here you see, this is the famous Montreal Cognitive Assessment. I know I'm calling in from Washington, D.C., and I've worked and looked up to Dr. Weiss throughout my career. And he's calling in from the Baltimore area, the Maryland area. But this is now, we're kind of shifting gears, moving up north to Canada. A professor at McGill actually created this 30-point screening test to evaluate patients, but all the different cognitive domains that affect our patients, like the visual, spatial, or executive function, right? Something like drawing a cube, copying a cube, or drawing a clock. Understanding how it is that our patients can do that. Naming animals, remembering 5 words, retaining them, and then asking to repeat them later is important. Language, remembering or being able to say a certain number of words within a 60-second time frame that might start with the letter, for example, letter F. Understanding our ability to do that is so important. Of course, our orientation questions like, what's the date, the month, the year, the day of the week? Where are we exactly right now? What city are we in, right? We were joking earlier that maybe the city behind me looks like Prague, but in fact, it's just Georgetown in Washington, D.C. But our goal is to be able to kind of think about to what degree are our patients affected cognitively, and to understand more the different components, the different aspects of memory that might be affected. We can go as far as doing a neuropsychological evaluation. This is different than just a screening or a cognitive evaluation that we might do in our clinic. In fact, we might actually write a referral to go see a neuropsychologist, which can do an in-depth evaluation of our cognitive function and understand and help us diagnose what kind of degree or what extent of cognitive impairment we're experiencing. And for that, I mean, are we dealing with a mild cognitive disorder? Is it something that's more moderate? What aspects of memory or cognition are affected? These things can also be important in determining whether or not someone is a DBS candidate, right? So understanding the in-depth ability to think through things, remember things, and our cognitive potential is important before getting DBS. So what do we tend to see over time is, and there's a little bit of a gender difference, we might see it more likely based on data in women than in men, but very slight difference. Patients with Parkinson's may, in fact, over time, might have a lifelong risk of developing cognitive change or cognitive impairment. In fact, if you look early on in some data sets of understanding first appointments with Parkinson's disease patients, up to 19% of them had some degree of cognitive impairment at the time of diagnosis. So we might actually see cognitive change and Parkinsonism kind of all occurring around the same time, especially when we think about that in our clinical setting. So if you see here, cognition and the different components of cognition, I might ask patients, and I make this mistake myself, do you have any trouble with your memory? Some patients might say, no, there's nothing wrong with my memory. I can tell you a story from a long time ago that really, when I first got married, or when I first, my first day on the job, or different things that were important, they can tell that story from start to finish in detail. So it's not all about long-term memory. Sometimes it's about short-term memory, our ability to maintain attention, as we talked about, and then executive functioning. And we're going to dive in a little deeper on what that means. But generally speaking, executive functioning means our ability to complete tasks in a successful way. So the cognitive types of changes that we see in Parkinson's disease cognitive impairment is we might not necessarily have trouble storing memory. We can store that memory into the long-term memory storage areas of the brain in the temporal lobe, but it's hard to retrieve sometimes memories. So that's where external cues can be helpful. And we can see preserved recognition of things, but it might be hard sometimes. That tip of the tongue like experience that sometimes our patients say, I'm in the middle of a sentence and I just can't find the word and it comes later, I'm struggling to retrieve the word. That is something that we tend to see, and we'll talk about why that is. Also, things like executive dysfunction, understanding concepts, problem solving, understanding that we can go through kind of like a recipe or following an instruction manual. Those are the types of things that executive function help us do. A lot of the times in our sort of profile, cognitive profile for Parkinsonism, we might see some trouble there. And then we talked about attentional impairment, right? Actually, reaction time, our ability, our agility of our cognition, our ability to kind of respond or react to external cues sometimes can be a little delayed. And we might actually have fluctuations in our cognitive abilities. Some hours might be better than others. Some days might be better than others. And that can be due to multiple things. The other thing that we tend to do is make sure whenever we're evaluating a case that there's not something reversible. We talked about the B12 levels, the thyroid function. We talked about folic acid, B1. These are all kind of nutritional things that we look at, or metabolic things that we make sure if there are ways to reverse some cognitive change. It's not always due to Parkinson's, right? So what we need to do is make sure that we've been thorough in our diagnostic workup. And we've ruled out something like an infection. Something as simple as a urinary tract infection can affect our ability to think through things and can cause confusion, or can trick us sometimes and make us feel like we're developing some memory loss, when in fact, it's something that might be treatable with antibiotics, for example. So when we think about the memory domains, this is a brain, okay? And what you see here is, it's as if we're looking this way, okay? And what we find is that the frontal lobe, or that area in the front, right here, that left frontal lobe, that prefrontal cortex, really controls our ability to maintain attention and to transfer a lot of that information that's been stored in the temporal lobes right here, right behind, near the ear area. That temporal lobe stores information, but how do we retrieve it? We need our frontal lobe to be functioning and to be powerful. And in order to retrieve information, if we have a frontal lobe that's helping us do that, then that's how we do so quickly. But in Parkinson's, sometimes that frontal lobe function can be affected. And that can impair our ability to kind of retrieve some of those stored memories that are definitely there, which really, really helps. Things like cognition therapy or cognitive therapy, things like reading, things like exercising our mind, keeping intellectually stimulated, social activity, all of those things help us reinforce our frontal lobe. And that helps us be able to retrieve those thoughts and memories that we've stored in our brain that hasn't been affected by Parkinson's. So the other things that we think about when it has to do with executive function is things like verbal fluency. So when we think about being able to speak and in a fluid way, that test that we ask our patients to do in 60 seconds, can you think of all the words that start with this one letter, right? That might be a little delayed. Things like clock drawing or planning, those things are also affected with executive dysfunction. But here you can see also that attention is very much a function of our executive function. And it's that same brain area that has to do with focus that also has to do with our executive function. And so we might find it difficult sometimes to do things like multitasking. In fact, walking is very much a cognitive task. We have to be able to focus on our walking in order for us to be able to complete a step. We have to be able to integrate all of the visual and auditory cues that are coming our way. Imagine each time we're walking, it's hard to do that sometimes in Parkinson's. But if we're cognitively affected, it can be even harder. Imagine walking through a doorway, having to step over a small kind of a barrier obstacle underneath, like a mat in front of a door, and we're trying to get through a doorway. And we're listening to someone that's talking to us. And we're looking ahead and we're seeing that someone is waving at us. All of those cues need our ability to have this executive function in a powerful place so that we can successfully accomplish a task like walking. So don't forget that cognition is very much a part of our ability to walk. And we'll talk a little bit more about that. Now, when we think about cognitive impairment or dementia, it's very important to understand that when dementia or cognitive impairment kind of become the centerpiece of our discussion, it can be hard. It can be hard on our patients. It can be hard on our family members. And it can be sometimes maybe as distressing or maybe more distressing than some of the motor symptoms that can occur in Parkinson's. So I mean to say, let's not neglect it. Let's be able to diagnose it. Let's do our cognitive evaluations. Let's not forget that the brain is very complex and it affects our ability to walk, but it also affects our ability to think through things and our cognitive state. So when we think about Parkinson's disease and what that means in terms of development of cognitive impairment, usually we think about Parkinson's disease. If we have symptoms like tremors, rigidity, slowness of movement, all those motor symptoms that happen, and you've had those for at least 2 years, and later on, and it could be much, much later, it could be 5 to 15 to even longer years before we start developing cognitive change, just even mild cognitive change. What we might see is if we diagnose someone that way, then that usually means that we're dealing with a Parkinson's disease with cognitive impairment or dementia, as opposed to Lewy body disease. This is a question that I get a lot. So what is Lewy body disease and how does it relate to Parkinson's disease? Well, whenever we see that there was straightforward Parkinsonian motor features that preceded the cognitive impairment, sometimes by many, many, many years, then we can say that that's most likely a Parkinson's disease with cognitive impairment or dementia. But if we're seeing that within 2 years of motor symptoms starting, or even if the movement symptoms occur after we have some memory impairment, that's usually when we start thinking about Lewy body disease. And we think about them almost on the same spectrum, and they're not at all the same thing, but they're different in terms of how the chronology of how things progress. And so, as we mentioned, Lewy body pathology is very important. Now we think about dementia with Lewy body or Lewy body disease or dementia, but Parkinson's disease and Lewy body dementia are all caused by this protein accumulation within the neurons. And we might see those Lewy bodies within the neurons. It just depends what aspect and what part of our brain has had an increased amount of those Lewy bodies and how they become affected. Now, there's different things that we can think about and how it is that our different proteins that can affect our brain as we get older, they move in different directions. You see, when we think about Alzheimer's disease, we think more about amyloid plaques or tau inclusions that can happen. That's more of an Alzheimer's disease memory loss. You see the first two rows. And the way we see that accumulation of that protein in the neurons, the way it flows and starts from start to finish is different for the different disorders. Alpha-synuclein, as we mentioned earlier, starts, most likely that accumulation can start in the olfactory cortex, the olfactory bulb, and the myenteric plexus of the GI tract. And it moves its way up based on a hypothesis called the Braak hypothesis. And then it moves its way up into the brain, but it moves upwards. And it doesn't reach the cortex until later on in the condition. And that's when we start seeing memory changes. In Lewy body disease, we might see features of Parkinson's disease, Parkinson's movement symptoms, cognitive changes, or we might also see some changes in our ability to see things for what they are. We might see some visual hallucinations or some changes in our ideas about things. We might feel scared sometimes about people or scared about things. We might have some paranoia-like experiences. That can happen in Lewy body disease. It can also happen in Parkinson's disease as we get older. And so what we see here is that whenever we have one condition, we might see aspects of other conditions. So we might see aspects of memory changes. There's different ways of using diagnostic tests in Parkinson's disease. We might be able to do something called a PET scan, which looks at the actual FDG or the metabolism of those neurons. And we might be able to help us understand, how much of the brain is affected. Is it just a part of the brain? Is it the whole cortex? And we might want to superimpose that information and understanding, are we dealing with a dopamine deficiency as well? So all of those things can be done, and they're done with what are called neuroimaging nuclear medicine biomarkers. So why do I talk about all this? What does this all have to do with what we can do to fix it, right? I tell you all this stuff, and my goal here is to really stay positive and to stay hopeful. My goal here is to show you right here in this slide that if you look at an unaffected a person that doesn't have Parkinson's disease or doesn't have Alzheimer's disease for that matter, what we see is that we see a high level of acetylcholine. Acetylcholine is a very important chemical. We talk a lot about dopamine, but acetylcholine is an important chemical for our memory function. So in Parkinson's disease, in comparison to Alzheimer's disease, both conditions have a decrease in acetylcholine. But in Parkinson's disease with dementia, we have an even more, a larger deficit in acetylcholine, which means that if we use therapies that help augment acetylcholine, then I think we'll be more successful in being able to see a reversal or an improvement of our cognitive abilities. And that maintenance of hope is important, because if you understand the science and you understand the neurotransmitter changes, it helps us understand how we can fix it, right? So here you can see the guidelines for treating dementia and cognitive impairment in Parkinson's disease, based on the most recent guidelines by our wonderful Movement Disorders Society that we all look up to and we continue to be a part of and understanding. But here you can see we have different medications. We have a medicine called donepezil. That is an acetylcholinesterase inhibitor. Okay, how many syllables do we need before we can say a drug, right? It's like so many sometimes. And so what I mean to tell you is that acetylcholine is important. Acetylcholinesterase breaks down acetylcholine. So if we use an inhibitor to that enzyme that breaks it down, we in essence ultimately augment acetylcholine levels. So the medications that can do that are donepezil, rivastigmine, which is available in a pill or a patch. And if you look at that, actually it's clinically useful based on the guidelines. Galantamine is another medication that you may have heard of that also augments acetylcholine levels. And then we have the glutamate or NMDA receptor antagonist called memantine. That is right now something that can be used for cognitive change, and we can use it in combination sometimes with an acetylcholinesterase inhibitor, which is helpful. But also there's been some studies using rasagiline, which is a monoamine oxidase inhibitor, monoamine oxidase B inhibitor, and potentially can be used, although right now, based on guidelines, it's still an investigational indication. But if you see, rasagiline also might be a medication that could be helpful potentially for cognition. And that's a medicine that augments dopamine. So that kind of shows you that it's a multifaceted approach, but neglecting the cognitive medications is not advised. If we could use cognitive medications, that can be very helpful. The other things are not all medicines, right? My mom always tells me, I know you're an allopathic doctor, but it's not all about the medicine. And I can't agree more. She says, you need to do things like exercise. And my aunt has Parkinson's. And the first thing I told her when she was diagnosed, I said, you got to exercise. And she said, all right. And so exercise is important, even for cognition. But you can do things like cognitive therapy, like I mentioned. There's something called communication therapy done by a speech therapist. Even exercising our minds with speech therapy can be helpful for keeping our mind at sharp and cognitively agile. So these are all things that we can think about. Now, I'm sorry, I don't want to forget this. There's research that has suggested, and there have been multiple studies that have looked at the effect of improving acetylcholine levels, and it's showing potentially a reduction in falling. And that kind of opens our eyes sometimes in understanding that link that I mentioned. Remember, when a patient's walking through a doorway, stepping over a mat, listening to someone talk behind them and seeing someone wave in front of them, that all takes a lot of input, cognitive input. And so if we can strengthen that cognitive ability, it helps us a lot. Now, neuropsychiatric screening is something that we do. We ask about if a patient's experienced visual hallucinations where they see a person or an animal in the room, if they felt a person, or if they might look at something that transforms in shape, like a belt on the floor might look like an animal, or if you look outside, a mailbox might look like a person for a moment, but then it looks like a mailbox again. That's called an illusion. And all of these things can be part of our understanding of cognition and our neuropsychiatric state. We also ask about agitation, understanding depression's role, anxiety's role, or if there's changes in emotion, right? Or if there's too much happiness or euphoria. The other thing we ask about is indifference. If people might feel less interested in activities with family or friends, and how that differentiates between depression, if that's related to apathy or indifference, rather than depression. The other thing is some disinhibition, acting impulsively or not being able to control ourselves from saying things sometimes. That's something that we screen for. And then, of course, we talk about our ability to understand that nighttime behavior and that important sleep aspect to things, understanding if it's easy for our patients to stay asleep. Are they acting out their dreams? Are they experiencing snoring? Are they feeling daytime sleepiness, which can affect our ability to think through things? So all of those things are important. So when we think about what it is psychosis or hallucinations bring to the table, remember, everything that we do is to understand ultimately the chemicals that might be the upstream cause or what's affecting our patients. So understanding dopamine and Parkinson's through that lens is important. We've talked a lot about acetylcholine and the importance of cognition from that lens. But there's also serotonin. Serotonin is our happy neurotransmitter. It helps affect our circadian rhythm. It helps us feel, when we have enough serotonin, it helps us stay alert. And then norepinephrine, of course, right? Norepinephrine is another neurotransmitter, which is also important for energy, our ability to kind of stay alert, and it can control our blood pressure. We know our patients with Parkinson's might have lower blood pressure due to the Parkinson's. And so what do? When we evaluate a patient, we want to make sure that we do also screen them, make sure that we understand their neuropsychiatric state is what it's called. Now we think about cognition. Cognition is important, but that neuropsychiatric state is also very much a part of the picture. And remember, our medications can also enhance or cause things like hallucinations and delusions. So understanding that is very, very important. And if we were to think about that idea of the visual hallucinations and where we are in terms of our ability to move, sometimes we might see a relationship between patients that are having freezing and motor function freezing. So when they're walking, they might freeze, or if they have a little bit of spatial misjudgment, difficulty estimating distance of objects when walking. Those things sometimes can trigger a cognitive specialist like me to think about, really, if a patient's starting to freeze or is having spatial misjudgment, or sometimes is seeing double. Sometimes double vision can be part of something that a patient might experience. I might say, hey, let's make sure that we screen them for any visual hallucinations or any sort of neuropsychiatric things that can happen in Parkinson's. Remember, it's all related, so whenever we think about visual hallucinations, cognition, depression, REM behavioral sleep disorder, what that indicates is that there are multiple aspects of our neurologic system that are affected. So what do we do about it? Again, now I gave you all this information, all this context, but the goal here is to also say, how do I help you? And the way we think about helping is by using medicines like clozapine or quetiapine, or a medication called pimavanserin, which is a medication that can be used for Parkinson's disease psychosis. So all of these things are medications. These are the things that we look at, and so that we can really think about this therapeutically in a positive light. Now we're nearing the end of this. I am so happy to be a part of it. And I'm so excited to be able to present to everybody. And my goal here is to be able to, alongside Dr. Weiss and the whole MAPS team, really help us guide us through. Here you can see, when we think about DBS, let's not neglect our cognitive function. And then let's not forget to treat our mood symptoms. Our mood symptoms, we can use medicines that promote dopamine. Our monoamine oxidase inhibitors can help our mood. Our selective serotonin inhibitors can help our mood. And then we can think about all of these different aspects, all these different medications that treat depression and sleep. If we're having difficulty with REM behavioral sleep disorder, things like melatonin can be helpful, or things like clonazepam. And so I thank you. Thank you very much. I think we're here for the question and answer section, and I'm very excited to be able to answer anything that you all have.
Yeah, well, thank you very much. Yeah, so that was a wonderful talk, and I know it certainly covered a lot. You had a lot of material to cover, and you really covered it quite well. So we have a whole list of questions that were submitted prior to the talk, and of course we won't be able to get through all of them, but I'd like to sort of paraphrase a few of them. Here's a very relevant one. This patient's wife writes that my husband was hospitalized with a hip fracture, and he seemed fine before the hospitalization, but then became very confused and agitated and even hallucinated. And I was told that he had dementia, but he's home now, and after several weeks seems to be normal again. So what happened? Does he have dementia?
Wonderful question. Thank you, Dr. Weiss. And it's very important. This is something that we hear about as neurologists all the time. Unfortunately, when we end up in the hospital, first of all, that takes us out of our environment. When we are at home, our mindset is very much not affected by a change in environment. When we end up in the hospital, several things happen. Number one, we're going through a stressor. Any stressor, including something like a hip fracture, can really change our metabolic state, right? And lead to a lot of stress. That in and of itself can affect our cognition, our ability to think through things. Then you add to it a surgery that might have been had. Then you add the medications that might be treating pain. Those things can also affect our cognition. But then what happens in the hospital a lot of the times is, because we're being monitored so thoroughly, a lot of the times our sleep-wake cycle is affected. And that can lead to other issues. When we're not sleeping well, we get into a vicious cycle, and our cognition can very much be affected. We can get confused. We can even hallucinate or have delusions. When that happens, it's very important. The first thing that I do when I'm covering the hospital and I hear about this is I say, okay, let's see what medications our patients are on. Did we use a medicine that might lower their threshold to have hallucinations or delusions? Do they have an infection that ensued throughout this hospitalization, something that can be treated with antibiotics? It doesn't mean that we're dealing with cognitive impairment or dementia. It could just be what we call delirium or just a confusional state. And so identifying the different aspects that could be contributing to that state is important because we can remove those things that are causing it. And then the next thing that I do is I say, open the windows, open the shades, make sure our patients are sleeping at night and staying awake during the day. If they're making sure that our sleep-wake cycle is reset again, then that episode of confusion or episodic confusion can improve.
Okay, and on a similar vein, another patient asks, does carbidopa, levodopa, or the other medicines used to treat Parkinson's disease cause memory loss or dementia or hallucinations?
Good question. And we kind of have to, in order to answer it, we have to kind of understand that every time we take a medication, we're taking a risk, right? And so we're always weighing risks and benefits. In order to help our movements, we might use medicines that improve dopamine levels. That helps our movements. But if our patient has a low threshold to have hallucinations because of the condition, sometimes our levodopa can actually enhance or cause hallucinations in some patients. And so it's very important to be gentle, to make sure that we're doing the right thing in terms of starting low and increasing slowly, always monitoring for side effects. Now, hallucinations is different than dementia, right? There are patients that when they have dementia, they might also have hallucinations. Dementia means you have difficulty remembering things. You might have slowness of thinking or inattention. You might have executive dysfunction. That is the kind of cognitive realm. The neuropsychiatric realm are the hallucinations and delusions. Our medicines that help improve movement, most of them do not cause dementia. They might, in fact, sometimes, especially early on in the condition, improve some cognitive impairment that might be there early on.
Now, another patient asks, are there any treatments that will help get rid of the abnormal proteins that damage the nerve cells in Parkinson's disease?
Wonderful. Wow, these are good questions, Dr. Weiss. So they're all good. I have a patient of mine who says, you can't say everything's a good question, because then not everything can be a good question. And I say, well, I'm always amazed by the questions that our patients ask. And that is a really good question, because we talked a lot about the protein buildup. Of course, that's not protein that we eat, right? It's not dietary protein. These are neuronal proteins that we use to maintain the integrity of our neurons. What we might see in patients with Parkinson's disease, right, is an accumulation of alpha-synuclein. Accumulation of alpha-synuclein leads to neuronal dysfunction, right? And so we lose that ability of those neurons to release dopamine. And so what we think is everything now that has to do with disease-modifying therapies is in investigational stages. So there are many clinical trials around the world and around the country that are looking at our ability to use therapeutics to reduce the amount of intraneuronal inside the neuron protein or alpha-synuclein levels to see if that in fact correlates with clinical improvement. Now, of course, we're looking into it. We're all learning. There are plenty of different clinical trials around the country that are looking at the disease-modifying benefits of different clinical therapies. So we are in a stage where we are investigating and studying it, but there's nothing FDA approved for that for Parkinson's disease.
Another patient asks, I've seen advertisements on television for something called Prevagen. Does this work for patients with Parkinson's disease, or are there any vitamins or supplements that will help my husband function better?
You got it. And I hear about Prevagen a lot from my patients. And my answer is really that I don't know too much about Prevagen. I've looked a little bit at the clinical studies that they have published, but in reality, I really rely on things that the NIH has published, things that the FDA has approved as true therapies for cognitive change and Parkinson's. So I usually would recommend, aside from all of our medicines, I joked about my mom saying, don't always use medicines, think about nutrition and exercise and sleep. But there are things that we do recommend for cognitive for improving our cognitive potential or reducing decline as we get older. Things like omega-3 fatty acids that we find in our diet. If we can enrich our diet with more omega-3 fatty acids, that can be helpful. Things like coenzyme Q10 might be a supplement that could be helpful. We also think about the B complex vitamins and how important those are. We talked about B12. B12 is so important for our neurologic state. Things like depression or memory loss can occur just because of low B12. Where do we find B12? We find it in meats. So a lot of vegetarians might, in fact, unfortunately, be suffering from B12 deficiency. Or B1. In people that that drink a lot of alcohol, sometimes we'll check a thiamine level. Thiamine is B1. And those are things that we can actually replete with something like a multivitamin. A multivitamin might be helpful to be able to replete B1. So those are the types of things that we think about when we think about supplementation and improving or reducing decline as we get older.
Here's another, I won't say a good one, but an interesting question. My husband is mildly confused, but I think he is still a good driver.
Yes.
Is it safe for my husband to continue to drive?
This is one of the hardest conversations to have about driving and driving safety. My rule of thumb is, if there is any concern, either from a patient or someone that knows the patient, I usually say, if we can avoid driving, let's avoid driving. Now, for me to just say that is a big deal. And I understand the potential implications of me saying that. But what we can do a lot of the times, first is take it one step at a time, right? If anything, if I can impart hope and positivity with this conversation, is that our medicines that improve cognition, they can work and patients can get better cognitively. So I usually say, well, if we have cognitive impairment and we're having some effect from that cognitive impairment on driving, let's see if we can improve the cognitive impairment. Maybe if we take it one step at a time and we do a driver's evaluation, once we've improved your cognitive abilities, maybe we can see if there are certain things that you can do in terms of driving. But an official cognitive evaluation is something that we do recommend, and an occupational therapist can in fact do those driver evaluations, and they will write a long report, oftentimes either stating that a person can fully drive, or they might have caveats. They say, well, maybe this person can drive based on everything, but maybe avoid highways or stay within a radius of the home to places that they know. So it's not a black or white answer, and there's different ways to address it.
Here's one. My husband is very slow to respond and doesn't speak very much in social situations. Is this a sign of dementia?
Yes. Well, we don't know, but remember all those tools that I mentioned? We screen for memory loss. We might screen for depression. We might ask about things like disinterest or apathy. Those are the things that we need to kind of tease out a little bit better, because right, if you do see a patient that might be more socially withdrawn, they might not be participating in social family events. These are things that, and they're slow to respond. We have to see, is this memory? Is it cognition? Is it executive function? Is it language? Are there ways that we can help improve our cognitive abilities? Is it depression? Or is it in fact that our patient might be suffering from some underlying mild psychosis, even small hallucinations, or the presence of someone in the room? That can take our attention away from our ability to respond quickly. Our reaction time can be affected. So there's multiple things that can cause what you mentioned, but the bottom line is that's a cognitive and neuropsychiatric evaluation that most likely has to be had. And that can be done by our movement disorder specialists and our memory disorder specialists.
My wife seems to cry very frequently, yet she denies being sad.
That is a really good point. Now this wasn't a question, it was a point. And that is called, it could be emotional lability. And that is so smart of a point. We screen for something called pseudobulbar affect. Whenever we think our cognitive abilities, we can't neglect pseudobulbar affect. If you feel an emotion and you cry, if you're sad, then that could be you manifesting your symptom of depression or sadness. But if you're crying or laughing and there's an incongruency, there's not a relationship with the mood that usually leads to that action. So if you're not happy and you're laughing, or if you're not sad and you're crying, and there's a little bit of lability in that, or might feel reflexive, then it could be pseudobulbar affect. And that is a different entity, and it has its different treatment. So pseudobulbar affect actually can be treated. And sometimes that crying that happens it's not uncommon in our patient population, is in fact not depression or sadness, because there's no underlying emotion that's leading to it. It's more of a reflection of the neuronal changes that are happening in the frontal lobe and through the brainstem. There's a treatment for that specific thing.
My husband reports that during the day, he goes through brief periods of what he calls brain fog, and then he seems to snap out of it. I can't seem to help him. Is there anything we can do?
Yes, so that brain fog, you mentioned, we've heard it. Dr. Weiss and I have heard that before. It's hard to know if there's not an underlying cognitive change that's leading to that. And so whenever we think about brain fog, of course, I'm always screening for cognitive change, right? I think doing regular Montreal cognitive assessments or different cognitive screening tests is very, very important as part of our movement disorders analysis. But we are always trying to see, well, if it's periodic throughout the day, fine, that could be cognitive related. But it also could be, the first thing that comes to mind also is, maybe we're wearing off of our medicines. Could this be a motor fluctuation where between our doses of carbidopa, levodopa, we're seeing some cognitive slowing, some difficulty communicating, some fog, right? Some cognitive fogginess. And that foggy brain feeling can happen. The other thing that I always search for is orthostatic hypotension, times like that. If your blood pressure is dropping as a result of your medicine or because of the condition, that can lead to some cognitive fogging. So there's a multitude of things that can lead to that. But the bottom line is we have to put our detective hats on and figure out, is this blood pressure change? Is it wearing off of your medicine? Should we adjust your carbidopa, levodopa regimen? Should we use extended release formulations or adjunctive agents to help stabilize so that you're not wearing off? Or is this in fact, periodic cognitive fluctuations, a manifestation of an underlying memory loss condition?
Words are sometimes on the tip of my tongue, but if I wait a minute or two, I can remember what I was trying to say. Does this indicate early dementia?
Great. Yeah. Well, that happens, to everybody. It can happen under stressful situations, happens to me during presentations. It happens if we're sleep deprived, which I'm sure we've all been sleep deprived before. And I'll sometimes start a sentence and I'll say, and because I'm typing on my electronic medical record, which has dominated our world now, it's a distraction from our patient care. And we're writing and I say, well, what was I in the middle of saying? And so you got it. That tip of the tongue phenomena is something we hear a lot about, and it can happen in our patients. It can be related to cognitive change, but it also could be a symptom of a little bit of subtherapeutic dopaminergic tone. So it could be if we're moving more slowly and we're a little bit slower in terms of our ability to think through things or even have speech output successfully occur, then it could be even adjustments to our movement medicines can actually help with that.
And here's another question on the same line. How do I know whether or not I am being over-medicated with my Parkinson medicines?
It's a good thing to think about. Of course, it's a balance. Everything is a risk and benefit. And the difference between a successful therapeutic medication and sometimes a medication might be the same medication, but a higher dose and a side effect, sometimes that window is narrow. Sometimes we'll see, doctor, I started on my medicine and I'm walking really well, but then I feel lightheaded a lot of the times when I stand. That's something, unfortunately, could be because our patients are susceptible, for example, to low blood pressure, and we start them on a medicine to improve their walking. They might be walking a lot better, but then they say, but I'm feeling a lot of lightheadedness. And so tolerability is a major component to our analysis and how we're going to treat somebody. So if someone is feeling lightheaded while they're on a medicine that's improving their movements, we may want to evaluate their blood pressure, because there are medications that can help stabilize blood pressure so that we don't have to sacrifice our motor stability, and we don't have to reduce those meds. But it's a great question.
So I think we're getting near the end. This will perhaps be the last question. I enjoyed your talk very much. I have a single daughter and want to know whether you are married.
I didn't know these were live questions. Wow.
I got a live one.
Oh, that's so nice. I thank you so much. That's so nice to hear. No, I have. My wife is 3 floors up. I live in a townhouse, and so I'm in my little office. I know I have a Zoom background, but okay. Thank you for asking.
They're very disappointed. Well, thank you so much. This was really very, very informative. And as I mentioned earlier, this talk has been recorded. It will be available at the MAPS website. And we do ask people to fill out their evaluation forms, which is very helpful for us in terms of planning for future programs. But thank you so much, sir. It was a wonderful talk. And I hope that the participants, certainly I'm sure they gained a lot of knowledge from this. So thank you so much.
Thank you for the opportunity, Dr. Weiss. Thank you, everybody.